Okay. So the topics in exam, mostly eye examination. There will be different kind of finding in eye examination, and according to this, we need to proceed for the further examination. And one important area is sometimes they say whole cranial nerves, and that time management is sometimes difficult. But if this is the only eye examination, then it will be like a little quicker. I mean, better to perform within 5 or 6 minutes. So we'll see how to examine the eye. So suggested approach is that the same pattern is same. Okay. So we'll start with looking at the child like 4DS. Okay. So 4D stands for, can anybody suggest 4Ds?
Dimension, dysmorphic feature, distress, and
Yes.
device.
Yes. So distress, device, then
Dimension, dysmorphic.
dimension is important every station. So the growth including the head circumference, because here if there is suppose CP child, sometimes head circumference may vary. Okay, so that's why with dimension this head circumference is always very important. So 4DS. Okay, so that is common for every station. Now we need to look at the child for just like any clue is there or not, like squeam, ptosis. According to this, approach will be different. Okay, so first of all, general observation. See, general observation 4DS, whether the child will be distressed or not, and at the same time, mentality. So sometimes the child may have the mentality level, I mean low IQ level. So that's why we need to talk to the child at the same time. And these are the 4DS, that is very, very important. The second important area is whether any kind of glass is there or not, because if there is glass, then the task is double. We need to examine the child with and without glass. So that is sometimes difficult again. Okay. So if there is glass, so we need to identify the power of the glass, whether it's concave or convex, whether it's hypermetropic or myopic. So all these things we discuss. And after that, we need to check the eyes in very carefully in a close observation. That is also within this general observation. Okay. So what are the things we'll see in close eye observation? That is whether any kind of conjunctival injection or redness or swelling is there or not. So there are a few conditions where you can we can get some conjunctival redness or injection like that. Can suggest anyone what are the exam cases related to this redness of the conjunctiva?
Ataxia, telangiectasia.
Excellent. And
Kawasaki sometimes.
Kawasaki, it's rare, but yeah, there will be congestion, right? Anything more which is related to the eye examination?
Uveitis.
Periorbital cellitis.
Periorbital cellulitis is very sometimes okay possible, but the thing is more common is uveitis. Someone says uveitis, that is right. Okay.
Yeah.
And whenever there is uveitis, we need to check few other things, right? Like related system, which will be the related system at that time. MSK.
Yeah.
So the related MSK, that is joint examination, right? So joint examination at that time will be that will be in the part of, in order to continue my examination, I would also like to examine the joints. This comment need to be added. Okay. After that, there is another important area, that is pupil. Okay. So what are the abnormality can be seen in people? Can anybody suggest what are the abnormality can be there?
Irregular pupil in uveitis.
Huh?
Irregular pupil in uveitis.
Irregular pupil in uveitis, right? And
Coloboma.
coloboma is another important area. Coloboma. So eye examination easy, but sometimes difficult. If we miss this small finding, then that is very bad. They will be downgraded, all of us, if we miss. Okay.
Yeah.
So we need to observe the pupil as well, and at the same time lids. So what are the abnormalities in the lids? Eyelids. According to the yeah,
Ptosis.
ptosis,
Ptosis
right?
in myasthenia gravis.
Yes. Any other condition where ptosis is a vast
Third nerve
topic.
palsy.
Third nerve palsy.
Third nerve palsy, excellent. And
Corners.
Horner's
No.
again, yes. And
Facial nerve palsy.
facial nerve palsy, ptosis sometimes possible, yes.
Unable to close.
Sometimes, yes.
Noonan syndrome.
Noonan syndrome bilateral, right. So these are the causes of ptosis. So if there is ptosis, we need to think what may be the reason for this ptosis. And according to that, we'll proceed for the examination, right? So this is step number 3. And now that is important step 4. Okay, whether child is able to see or not. So we need to test both the eyes separately because they are previously giving a child with prosthetic eye, their favorite. Okay. So this sometimes this looks very similar with the normal eye, but if we miss, then the station is gone. Okay. So whether the child is able to see even without prosthetic eye, it is also possible. So the prosthetic eye sometimes very important examples. We need to assess separately. With even with light also, okay, perception light is there or not. So these are the 4 steps we need to assess first. After that proper examination, if you see the steps of the examination in the eye are very, very important. So here is the steps. There are 8 steps. So first we'll assess the visual acuity. Second, visual field. Third, eye movement, that is H-shaped. Okay. At the same time, you will get the nystagmus. If there is nystagmus at the at the periphery of the, whenever this object is moving to the periphery, the nystagmus will be more prominent, right? So this is step number 4. And there are another 4 steps is there, like accommodation. So accommodation very easy. Just ask the child to look at the finger and try to just put it near to the eye. So the eyeball will converge. At the same time, there will be pupillary constriction, right? So now, after that, the pupillary response to the direct and conceptual light reflex. So this we'll see how to examine step by step. And cover test again important. So why I have divided this examination in 4 parts. I mean 8 part total, 4 because every area, every part of this examination, there will be some finding chances is there. Okay, suppose if the child having some refractive error, most commonly, then it is possible that the visual acuity will be having some finding. Okay, now visual field. So sometimes if there is scotoma or something, in last exam in Singapore, there was a case with scotoma. So field of vision was not there in that. So visual field is that's why it's not like that. So we need to do, and we need to find out the area where exactly the child is unable to see, which area. Okay, so after that we'll find out, interpret the DDs where is the site of lesion. So that is the importance of this visual field. After that, H-shaped movement, we need to find out whether any kind of nystagmus is there or not, or eye movement especially helpful where there is a squint as well as some maybe third nerve palsy, or maybe there is if this paralytic squint, child will be unable to and follow the movement of H-shape. So at any area, depending on the lesion of nerve, we'll find out this nerve lesion exactly where and why this exactly why this palsy is there. Maybe third nerve, maybe sixth nerve, or maybe trochlear as well, fourth nerve. So accommodation again important. We need to see then pupillary reflex, direct and conceptual. After that, covered and covered usually needed for this non-paralytic squint. Okay, so we'll see the videos that will be more helpful. Okay, and after that, last, this is usually not asked in the exam to do, but we need to mention that I will just check the fundas with this fundoscopy. So these are the steps of examination. Okay, so most of the eye examination will be covered in this with these 8 steps. Okay, now again, if you see this general observation, already I just described the 4D MS, that is 4D we discuss. A means mentality and V vitas and S I forgot that. Anyway, so this part is must compulsory in every stage. After that, at the beginning, if you see there is a squint, then examination technique will be just like that. Check the child whether the sees both the eyes or one eye, corneal reflection, and after that, eye movement and covered and uncovered test. This is the steps in child with squint. Now, if there is coloboma, then all the examination need to do corneal cloud, maybe different type of finding. So we need to do these 8 steps, but mostly if this is squint, we can do these steps. Okay, it just is ABCD for the squint. And ptosis. To ptosis, most likely exam case. What are the exam case? Horner syndrome, maybe NERVE palsy. And last in January, there was a case was myasthenia gravis with bilateral ptosis. Ptosis is very important topic. We'll discuss in detail. So, yeah, ptosis. These are the exam case. After that, sometimes there may be anophthalmia, macrophthalmia as well. So we need to identify according to the finding. Okay. Now we'll move for first these 8 steps, which are very, very important to perform the examination. Okay. So eye examination, it's not possible online to practice, but I will just share the video so that will be helpful. Okay. So here is the steps of eye examination one by one. Can you see the screen?
Yeah.
So first, when we have entered the room, after that we need to introduce ourselves. Okay, and after that we'll take the permission and then proceed for the examination after washing the hand as well. Okay, so now the first step, we need to observe the child with sorry, 4DS, whether any kind of dysmorphism is there or not, whether the total 4DS in the face any dysmorphism is there or not. Okay, and after that, overall growth. Okay, growth parameters including head size. Okay, these are the important area. Then this child, this not child actually, this lady is just wearing glasses, so task is done. We need to examine the child. I mean, yeah, without specs and with specs, two different, stages. Okay, so now we'll see how to examine the eye first. Okay, so I'm just trying to play the video so that you will have.
And date of birth, please.
Yeah, my name's Grace Barrington and I was born on the 26th of January 1990.
Okay, Grace, we'd like to examine your eyes today and test your vision. Is that all right?
Yeah, that's fine.
So are those the glasses that you normally use to...
So what we discussed just now, the first step is checking the visual acuity. But before that, if there is any doubt, just check whether the child is able to see or not in each eye. If the child is not able to see, at the same time, quickly we need to assess the light, I mean, perception of light is there or not. Okay. So after that, we'll move for visual acuity. First step.
to look in the distance with?
Yeah.
If you could keep those on for me, please, and cover up your left eye. And then with your right eye, read down as far the chart as you can.
T, B, H, X, U, A, H, T Y O V U A X T H Y X. That's it.
Okay, and if you could cover up your other eye for me, please.
Okay. T.
So each eye separately. So sometimes we can make some mistakes. So that should never happen in exam. Okay. So ask to cover the eye. After that, ask to read.
H X U H U Y.
That's great. Okay, now if you cover up your left eye again for me, please.
Yeah.
Got some little holes here. If you could hold those against your right
So this
eye.
step is not needed for pediatrics.
Look through the little holes and see how far down you can read.
T H A Y O U X. And that's it.
So now I'm going to test
Now
your
near
near
vision.
If you just read the smallest line that you can. If you can't read anything on that page, then we'll test with the other page. Grace, if you could cover up your left eye for me, please, and read the smallest line that you can do at arm's length with your right
Each eye separately.
Sense of breaking new ground by actual experience is still more apparent in the arts, and here it has wider scope and a greater basis of reality.
That's great, thank you very much. And if you could do the same with your other eye for me, please.
As we went along in
Okay, Grace, I'm going to check your visual fields now.
So first step is visual acuity, that is covered. This is the next step. Okay. That is second step. We will assess the visual field. So if the child has any kind of problem in the vision, maybe refractive error, or maybe some corneal clouding, or maybe what that's it, like, I mean cataracted, any problem in the eye, the visual acuity will be, some finding will be there. Okay, the child will be just having some problem in the near or maybe distance vision. We need to find out. And this is the second step. This is important because I just said last in Singapore, the finding was in this particular step, visual field. There was photoma. Okay. So we need to find out where exactly the lesion. So here is the next step. Number 2, visual
You
field.
could take your glasses off for me, please. And if you could cover up your right eye for me, please. Have a look at my nose here. Is there any part of my face that's missing?
No.
And then cover up your left eye for me. And have a look at my nose again. Is there any part of my face that's missing?
No.
Have a look at my eye there. And say when you can see my fingers.
Yeah.
Say if they disappear.
No.
Tell me when you can see my fingers.
Yeah.
Say if they disappear.
No.
Okay. Say when you can see my fingers. Say if they disappear.
No.
Say when you can see my fingers.
Yeah.
Say if they disappear.
No.
Okay, so how you will compare that there is any kind of defect in the visual field is there or not? Can anybody suggest?
Comparing with our visual
Yes.
field.
So if we practice like that, so whether I am examining child, then we will compare with myself. That yes, I am able to see the fingers, which is maybe sometimes weekly movement maybe applicable in that particular examination. So if the field of vision is saying yes, I am also able to see, then I can ask the child. Whenever the child will be able to see, at the time he will say, and we need to assess with our field of vision. Okay, that is important. In that way, we will find out. Otherwise, that is sometimes very difficult. This was the second step of examination. Okay. Now
I'm going.
Here inspection we have already done earlier, but here they said inspect the pupil very carefully because some of the finding may be there in the pupil. Okay. After this video, I will show you few of the slides. I mean photos that will be easier to find out. Okay. So here
going to examine your pupil responses. So if you could fix on an object in the distance for me, please.
Okay.
I'm going to shine a bright light in your eyes. It's going to go from one eye to the other eye.
Okay.
They're jumping into that step, direct and consensual reflex, but it depends upon your protocol. I mean the steps. So you can do this earlier or maybe later. Anyway, we need to cover all the steps. Okay. So here is a small video just in the right hand side. Also, just try to see this. Okay.
Now I'm going to go from one eye to the other eye.
Now this is a nice example. Can anybody identify this? What is exactly this condition? I'm playing one. So when this, sorry,
It's written that, Dr. Pranab, relative apparent pupillary defect.
oh, it's written. So first time this is in the left side. They are just give the light. After that, there will be so instead of constriction, there will be dilatation. But this is very nicely. Yeah, look at this. Constriction, dilation. Constriction, dilation. This is just the opposite.
I'm now going to test how your pupils respond to focusing close. So if you could have a look at the light switch there in the distance.
Okay.
And then have a look at my finger here. Okay, great. So I'm going to check your eye movements now.
Okay.
If you could have a look at this red dot for me. Are you seeing one?
So if in the exam case there is paralytic squint, just like NERVE PALSY, which is the most common exam case, and like 6 NERVE PALSY, then this step is very important. Okay, because apparent or just non-paralytic squint, the child will be able to move the eyes, okay, according to the giving direction. But if this is paralytic squint, the movement will be restricted. So for this reason, this step is very important, eye movement. So that will be just a shape of H. So try to follow this.
Or two red dots?
One red dot.
Okay, if you could follow it with your eyes and keep your head still for me, please. And tell me if you get any double vision. Any double vision there at all?
No.
Okay, thank you.
So this is
Okay, Grace, I'm going to have a closer look.
basically this step is not they are not allowing to do this step, but we will definitely mention in our examination. Okay, otherwise, or if there is any ophthalmoscope, we need to just use this one, because sometimes some storage diseases may have this reflex.
Look at your eyes now with this machine here. If you could have a look for me in the distance over there, perhaps at the light switch. I'm going to come closer and there's going to be a bright light. I'll pop a hand on your shoulder so that we don't bump into each other.
Okay.
Okay, and look at the light for me.
So this was steps of examination. Okay, so what will happen? Dr. Maya, your camera is on, I think. Okay, so just a minute. Okay, so again, we need to memorize these steps with practice. Okay, without practice, this eye examination is totally impossible. Okay, so first thing, checking whether the child is able to see or not. Then after that, visual acuity, visual field, eye movement, and at the same time, we'll find out nystagmus. If there is nystagmus, that will be more prominent during the checking of eye movement. Okay, at the periphery, wherever our fingers will be at the just far away from the eyes, this nystagmus will be more prominent. Now here accommodation, after that pupillary reflex and covered. So covered uncovered test is not has been there, so that is different. But we'll see another video to check it, because if there is non-paralytic squint, we need to do the covered uncovered test. And there's some beautiful findings with there. Okay. So now what I'll do, we'll see some finding. Just you can have a look. Here in the first picture, there is what is that called?
Coloboma.
Coloboma. Right. So coloboma, if it is not previously given, but if the coloboma, if it's there in the exam, we need to identify and we need to examine according to the steps. And after that, we will give the finding and we will just give our diagnosis that this is the condition where this coloboma is found basically. Can anybody suggest what are the conditions? Sorry?
Charge
syndrome.
Yes, Charciner is one of the findings, but Charciner is rare, isn't it? Charciner is rare. And any other, yeah, possible, definitely.
Golden hair syndrome.
Golden hair syndrome. Any other? First of all,
Trisomy. Trisomy 13 or 18, I think. One of them.
Okay, but you need to better to avoid such very rare cases. Okay, trisomy is very difficult to say in exam because they are most likely in the neonatal age there will be some problem and this child is difficult to survive this.
Okay.
So anyway, so first DD will be autosomal dominant condition which may not be related to any of the syndrome. Okay, so it can be autosomal dominant. So we need to look at the family. If the other family member is there, it's not just for this coloboma. In clinical station, for every station, sometimes we need to remember that every station we need to be very careful about the parent. Okay, or maybe some other sibling may be there. So they will be keeping the other sibling if this is autosomal dominant sometimes. So most of the cases, parent will be having the same finding. So this autosomal dominant is the most common, and after that, this can be isolated as well. That's what I'm saying. Okay. After that, Wilms tumor association with aniridia, there will be total loss, not in this partial loss, aniridia, and charge association, as you said, and the third one is golden syndrome. Okay. So these are the degrees. And what are the component of charge syndrome?
Loboma, heart defects, renal defects, retardation, genitourinary, ear defects, and A is anogenital. Anal.
And yeah. A for atresia, corneal atresia.
Oh, coenal atresia, okay.
So basically, if this case is in our exam, we need to say that I will, in order to continue my examination, after this examination, I also would like to check the heart and genitourinary system.
Yours.
Okay. And ears. Sometimes growth restriction will be there. So growth we can see all over in this, like whenever we are entering the station, we can have an idea about the growth. This would be that. So look at this child. This looks very normal, but here in this area, if you see the eyes closely, here is the same finding. Okay, this is another picture of the same finding. So this finding may be in our exam. So now this is the second picture. Okay. So can anybody suggest what the picture is saying? What may be the finding?
Left-sided ptosis.
Left-sided ptosis and
Idriasis.
mydriasis, right? So if this case is in our exam, then what will I say?
Horner syndrome.
Not syndrome, okay. And
Myasthenia gravis, usually
Third lump palsy.
unilateral.
so most commonly this is third lump palsy. First we need to exclude third lump palsy because there will be ptosis as well as dilation of pupil, mydriasis. So for Horner syndrome, what the other component we need to assess?
Usually
Okay.
myosis, enophthalmos, and hydrosis.
Yeah. All these four component, if it is there, then we diagnose as Horner syndrome. Otherwise, that will be sometimes difficult to say. But third lump palsy is most common exact case. We need to keep in mind. So eye deviation will be
Outward and upward.
Down. Here, somewhere here. So this is not classic, but somewhere here. Down and out. Right. Got confused.
Down and out, yes.
Upward will be only just fourth cranial, okay? That is trochlear nerve palsy. And sixth will be medial deviation, right? So now, in the case, according to the case, we'll see if this is our exam case, then what are the tests we will do to examine this child? First of all, we'll assess the vision, whether the child is able to see separate eye. First this eye and second this eye. After closing one by one. Okay. After that, we will see distant vision and close vision. After that, we'll see the visual field, and after that, eye movement. So if there is third lump palsy, there will be some degree of restriction of movement of this eye particularly, right? So in this way, we'll find out the restriction of movement, and with this clinical finding, we'll confirm our diagnosis. This is third lump palsy, and after that, they will move for the discussion of causes. What may be the causes? Okay. So in this way, they will ask. Now there is another type of case. Now, what we have not discussed, there is no picture, guys. Just wait. So there may be several findings, just corneal finding, maybe corneal clouding, okay, or maybe some less dislocation, which is very difficult to see in just in simple observation, but fundoscopy or maybe some special aid is needed to see this. But we will see covered uncovered test because this is very important in if this is our exam case like squint. Squint is very common example, sir. So what will be exactly the finding? So here is a beautiful video. You just see, and once if you see now, you will never forget. This is the classic finding. Okay. Can you see the screen? Yeah.
Have the patient look directly at a target at least 10 feet away. Cover the left eye and watch for a movement of the uncovered eye. Repeat.
So what they say? It's covered and how to test? We are covering this eye, right? And watching the movement of this eye. Okay. This is the technique for the examination. We are covering this eye, that is left eye, and watching the movement of the eyeball of this side, opposite side. Okay. So let's see what will be the finding.
Repeat this step a few times. Then do exactly the same thing in covering the right eye. If no movement occurs in the uncovered eye, the eyes are aligned.
So if there is no abnormal movement, I mean no movement in any eye with this covered uncovered test, there is eye alignment is normal. Yeah. Okay. Now, suppose there is some.
Here's a patient with esotropia. The left
So
eye.
I think you have an idea about this terminology, like esotropia, exotropia, and all these things. Eso means inward. Inward. Right. So look at this eye. This may be our exam case as well. Okay. So here esotropia is just this eyeball is. This is our, suppose this is our clinical finding. Whenever we have entered the station, we have seen there is finding that this eye is deviated medially. So this is esotropia. Okay. So after that, when we'll do the covered and uncovered test at the last, because few other tests we need to do before that, right? And after that, when we will do this our last test, this is covered and uncovered, then the finding will be most common. So this is a beautiful finding. Look.
Eye is deviated inward. As the fixating right eye is covered, the left.
Look. When this normal eye is covered, spontaneously the deviated eye comes in a normal alignment. Okay, just see this one more time.
As the fixating right eye is covered, the left eye moves outward to pick up fixation. As the non-fixating left eye is covered, there is no movement of the already fixating right eye.
Now this is exotropia, okay, outward.
There is a patient with exotropia.
So this finding also may be in the exam. So this eye looking just outside, outward deviated. Okay, this is the normal, I mean, finding in our, suppose this is the finding. So whenever we'll do the covered uncovered test, okay, suppose we are covering this eye, and at the same time fixation will be there. So this eyeball will move in this direction and will take its original position. But what exactly happens when this original position, this eye will be taking at the same time, there will be some compensation that this covered eye will move to compensate this finding. Okay, they will just let's see. Then after that you will understand.
The left eye is deviated outward. As the fixating right eye is covered, the left eye moves inward to pick up fixation. As the non-fixating left eye is covered, there is no movement of the already fixating right eye. Here is a patient with a left hypertropia. The left eye is deviated upward. As the fixating eye is covered.
This is the last type of finding, hypertropia, which is upward.
The deviated left eye moves downward to pick up fixation. As the non.
So whenever we are putting this cover, just beautifully they have shown one more time.
Downward to pick up fixation. As the non-fixating left eye is covered, there is no movement of the already fixating right eye.
So last case.
Already fixating right eye. Here is a patient with a left hypertrophy.
Okay, guys, I think you got this cover and cover test, how to do it. Okay.
Which eye has got problem, Dr. Pranab?
Sorry.
Which eye has got problem? What we can say?
So the presentation will be the problem. Okay. So deviation was the problem. So in first case there was, I forward that again. This was left or right. So
It was normal. Second was esotropia of the left eye. And third was exotropia of.
okay, so this is important. Let's see one more time. I think that will be helpful. Okay. I forgot that actually. That's why. This is important. So normal, you have seen the normal, so no need to see normal one more time.
Yeah.
Okay. So here, suppose is esotropia. Okay, this esotropia is there.
Yeah.
So this is basically the presentation. Okay, this is basically the presentation. So if this eyeball, this should be here in the center, right? But eyeball, sorry, not the eyeball. It's total eyeball. I mean the what is the problem? Pupil is deviated medially, like in this position. So this is not the normal position for this child. This may be due to refractive error or some other causes. So we need to find out these causes. During discussion, we'll discuss with the examiner. But we need to find out this is non-paralytic. If this is paralytic, now suppose what are the conditions where this eyeball, I mean this pupil will be positioned here? In which condition?
Lateral rectus palsy.
Lateral rectus palsy. In that case, this movement will be not there. And top of that, when we'll check for like eye movement age separate test, okay, just like this, we'll ask the child to see according to the movement of the hand, like a shape of age. Particularly, this eye will not be able to move laterally because lateral rectus is already paralyzed. Right here, this is non-paralytic. So non-paralytic, we need to confirm our finding with the covered and uncovered because they are, after covering the opposite eye, they are taking the repositioning. I mean the original position. Okay. So here medial deviation is there, and whenever we are putting some cover over here in the opposite eye, this eye, the pupil will go laterally to take its original position, like that. And for that reason, basically, this eye is compensating. This eye, opposite eye. Okay, this eye is under the cover. This cover will be there under the cover. This compensation will be there. That is the finding, basically. Okay.
So there is defect in left eye.
Left, right.
No, left.
Here is
No.
the left.
Patient's left.
Left. Yes. This eye is
And
defect.
why it's called non-paralytic then?
Because it's able to move. There is no nerve lesion. This is most commonly due to refractive error. Got my point?
Is it not due to sixth nerve palsy?
I think you got confused. Okay. So suppose this is sixth nerve palsy. Okay. So definitely sixth nerve lateral rectus, that is mostly here. Okay. Just pulling the eyeball in this direction, right?
Yeah.
So if this nerve is paralyzed, then eyeball movement will be not there. Just medial rectus will pulling the eyeball just like in this medial position, and this is paralyzed. That's why the position will be in the same position. Not will take the original position like this. Whatever we are seeing in the video.
Okay.
Okay. That is a fixed position due to paralysis. But here in this child, there is no paralysis. This is due to most commonly refractive error or maybe some other causes where.
Actually, we need to do the age test first, no?
Yeah.
Then cover test.
Definitely, cover test is the last one because there was no. What we have seen in the video, there was no cover test, covered and cover test. That's why I am separately just showing you the covered and uncovered test, right? This part was not in the video. What we have in London School of Pediatrics or maybe OSCE, glycematics video. In the first, what I just played just before that, there was not there this video with covered and covered test. Okay, so that's why we are covering this with another video. Okay, so this is most common cause is refractive error. Now see one more time how this beautiful finding is just elicited.
Here's a patient with esotropia. The left eye is deviated inward. As the fixating right eye is covered, the left eye moves outward to pick up fixation. As the non-fixating left eye is covered, there is no movement of the already fixating right eye. Here is a patient with exotropia. The left eye is deviated outward. As the fixating right eye is covered, the left eye moves inward to pick up fixation. As the non-fixating left eye is covered, there is no movement of the already fixating right eye. Here is a patient with a left hypertropia. The left eye is deviated upward. As the fixating eye is covered, the deviated left eye moves downward to pick up fixation. As the non-fixating left eye is covered, there is no movement of the already fixating right eye.
Okay.
So there is refractive error in which eye? What we can say?
Which one?
Which eye has got refractive error? The one which is which has got error.
Yeah.
Only
Right.
one eye has refractive error.
That eye is in an abnormal position. Most likely, this eye is having the refractive error.
Okay. Got it. Yeah.
So squint is very common exam case. So if there is squint, we need to perform this covered and cover test. This is must. Okay. Now, so just memorize by heart these steps, guys. This will help in the examination because the examination technique has continuing marks. So the whole examination will be giving the 2 marks, and after that the finding and DDs and discussion in this way. So suppose there is third nerve palsy. Suppose this is third nerve palsy. This is a third nerve palsy. This is our case. So what we'll do, we'll just practice over this one. Okay. Practice over this case. This is suppose 3-year-old child. and your opening statement is just do the eye examination. Okay. Then what will be your positive finding during the examination? You need to find it out. Okay. So according to the steps, we need to perform the eye examination within time. So that's very difficult without camera. Okay. So someone with willing to practice actually need to open the camera. After that, we can practice. Otherwise, verbalization is very difficult, especially in this eye examination. Otherwise, you people practice in your own. That is another issue. Okay, at home, whether any child is there, then you can practice. Whether or in the hospital, maybe you can practice. Okay. So now, if we are not practicing this one, we'll just discuss the most common exam case, that is third nerve palsy. Third nerve palsy is this one. Suppose this is not the exact position basically. Okay, there will be little different position, just like in down and out here with dilation of the pupil. Okay. So now this is suppose 3-year-old child. So I am just trying to explain the practice in a practice manner. Okay. So we'll cover this. So I will enter the station, and after that I will wash my hand. I will introduce myself with the examiner, and after that I will take the permission to examine, and I will expose the child. I will observe the growth, and I will talk to the child, including the head circumference. I will observe the growth, because a head circumference sometimes may be microcephaly there, or maybe implicit macrocephaly is there sometimes. Okay. So we after that we'll just start to examine the child. So before that, we'll expose the child to see whether any kind of other deformity in the body is there, like scoliosis, kyphosis, or any skin pigmentation, or neurocutaneous marker is there. Or not. All this observation is included within this 4DS and VITAS, including mentality. So I will talk to the child to check the mentality. Hello, suppose the name is John. So hello, John, how are you? This is a nice shirt. Which class? So we need to talk to the child. And after that, we'll just describe what exactly we're doing. First step is we need to check the eye, that is vision, whether the child is able to see or not. So John, can you see? Can you close your eyes? One eye. So John will be closing these eyes maybe. Okay. After that, can you see this pencil, John, or maybe the pen with me? So I'll ask, can you see this pen with this eyes? John will say yes. And after that, can you close this opposite eye now? This eye is closed. So open this eye. Can you see this? Yes. Okay. So after that, we'll move for visual acuity. Okay. So there will be some there need to be maintained some distance. After that, what is that called? That's the chart. Snellen's chart, right?
Snellen's chart.
Yeah. So distance will be near about 6 meters, right? So can you see this? Actually, close your one eye, and after that, try to see what is there. The letters are written over there. So John, at the time, visual acuity will assess that the child is able to see or read the letters or not. So at the time, we will assess. First of all, suppose this eye is closed. So with this eye, what is the exact visual acuity? Okay. Maybe.
Pranav, I have a question here.
Yeah, sure.
In this particular case, his left eye has ptosis. So when you're checking visual acuity, or maybe moving forward when you're checking the movements of the eye, should we raise the lid? Because that itself can give us a false visual acuity.
Exactly. So yeah, because I have seen several videos. Okay, so we need to ask the child, just hold the eyelid over here to not to just pull. I mean, not to suggest the position and downward, so that the vision will be clear. Otherwise that will be if this is partial ptosis, vision will be definitely affected. So yeah, we need to check this. And sometimes during our vision, I mean in checking of the vision, we need to ask whether this is I mean sometimes double vision is there, na? So we are checking with a pain. Suppose in the exam hall there is a pain in our hand. So we are asking the chair, can you see this pain? So at the same time, we need to ask how many pains are there. So sometimes if there is double vision, suppose diplopia is very common, na? Third nerve palsy, in every level, third nerve palsy, sixth nerve palsy, and fourth nerve palsy. So every lesion there will be some that there may be chances of getting diplopia. So we need to identify this. The child is having double vision. Otherwise, marks will be deducted. So after that, this visual acuity. So first distance vision. Okay. After that, near vision or close vision, or whatever you say, close vision, we need to assess. This is the first step. So this step done. After that, we'll do some visual field. So as this is we have seen in the video. Suppose here is here and here and here. So in this 4 direction, we will just bring there will be distance of 1 meter in between P1 us and the child. So we'll just sometimes move our finger to see the field of vision, to assess the field of vision. So suppose in this area the child is having difficulty in vision. I mean I am able to see this field of vision, but the child is not able to see this vision. At the same time, if the child is covering his right eye, I could also cover the left eye. Okay, right? If the child is covering the right eye in the same side, I will cover the left eye. Okay, this is the only area of confusion, so don't get confused. So we'll cover and try to check the field of vision. If there is some blindness or some visual field is defect is there, so we need to identify the visual field is defective here. Okay, so after that we'll come closer, just like this, in this direction. After that, in this direction. After that, in this direction. All the foldation we'll check. Check the visual field. Okay. After that, third, what was the third? That is eye movement. So here, eye movement is important because this is third nerve lesion. So child will not be moved the eye. Suppose here is the H-shaped movement. What we are doing. So if there is a paralysis third nerve, okay, oculomotor, so the movement will be restricted. Movement will be restricted, but I know that if this is lateral rectus palsy or sixth nerve, the movement will be restricted in this direction. But in third nerve, what will be the restriction of the movement in third nerve? I forgot that.
Almost all other than downward and outward movement.
Okay, so downward
because
and
SO4 and LR6 will become active. So
what was the
lateral
formula?
rectus will pull laterally. SO4 LR6.
All three SO4 and LR6. Right, so LR6 is there. LR6 is there. So I don't know. All three means maximum number of muscles will be involved, right? So if this is maximum, so eyeball movement will be. We need to assess. Actually, we need to see more videos. How will be the movement of the eyeball will be restricted in this particular lesion. But I know this is if this is a sixth nerve palsy, then the eyeball will be deviated medially and lateral movement will be restricted. There will be no movement in the lateral direction. Okay. So eyeball movement will be restricted with this H-shaped movement. That is field of vision. And after that, we can do reflexes or maybe check also HCP will be at the same time. If this is CP child or something, some nystagmus is there, we will also find it. There's no need to do any different type of test for nystagmus. Now accommodation at the same time, if we just asking the child to look at the distance, so just like my nose, and after that I will just come closer these fingers, just like here. Okay, then both the eyeball will be moving inward normally with constitution of the pupil. That is accommodation. But here already dilation is there in this eye. Already dilation is there. That will be not responding to this. So accommodation also will be affected, right? So this was the accommodation. Now, what was the next step? That is pupillary reflex, decision consensual. So also we need to perform this test. Okay. So in online it's very difficult to perform this test. So there will be dilation already is there. So in this side pupillary reaction and then constriction of the pupil will not be there, I think, right? After giving light, it is dilated. Constriction will be there or not after putting light?
No.
No. Yes. So in this eye, the light reflex, I mean, the pupillary reflex will be normal, but here there will be abnormal light reflex. Okay. Now, last step is just fundoscopy. So fundoscopy is not usually asked to do, but we should mention in our exam that I also want to do fundoscopy, and uncover test is mostly done in case of non-paralytic squint. But here we already find it out that this is paralytic squint. So we will just ask, because time is very limited. We will ask the examiner whether any need of doing this cover uncover. Mostly this is not helpful in paralytic squint. Okay, so this is the Sarna Palsy. So now they will ask few questions about the Sarna Palsy. Okay, what are the causes of? Okay, what are the findings? So finding, if we summarize, that finding will be it's a non-dysmorphic child with complete or partial ptosis. Sometimes diplopia will be there, so we need to assess the diplopia as well. Don't ever forget diplopia, because most common finding sometimes diplopia. Okay. Child will be complaining sometimes. The first complaint may be diplopia. Okay, so that's why diplopia is very important. So then that is pupillary. The pupil is deviated towards the outward and downward. This is the third finding, and the fourth finding is dilation of the pupil and failure the pupil to react with the light to light or to accommodation. So accommodation will be affected first of all, and pupillary light reflex will be not be there. Okay, so these are the finding in third-nerve palsy, right? So in a similar way, now let's complete this for third-nerve palsy first. So what are the causes maybe this for this third-nerve palsy? Can anybody suggest the causes of third-nerve palsy?
Raised intracranial pressure.
This is mostly sixth nerve, Dr. Nisha. Sixth nerve is mostly related to the increased intracranial pressure.
Infection, trauma, tumor, vascular cause.
Infection, trauma, tumor. So be specific. Infection, trauma, tumor. What type of infection?
Neuroinfection.
Yes, trauma, tumor is really important. Trauma is one of the most common cause. Okay, after that, tumor is another most common cause. After that, infection, mostly viral. Okay, that maybe EBV, maybe herpes zoster, or maybe some other varieties of infection. I am not recalling all this infection, but mostly viral. And after that, trauma, tumor we have discussed, and in this tumor, malignancy maybe one of the cause. Okay, and rest of the thing I forgot. If you remember, just causes of third-nerve palsy, you can write it down in the group. Okay. So as of now, I'm just unable to recollect all this. Now, another finding, sometimes there may be six nerve palsy. Six nerve palsy, another common case, common exam case. Okay, just like this one. Suppose we are practicing over the not giving any different picture. We are practicing over the same picture. Suppose in this eye, there is no ptosis. Ptosis is not there, but the eyeball is deviated medial. So, medially. So what will be the clinical finding? What will be the clinical finding? So there will be no pupillary dilation, number one. Okay. So I will be already deviated medially. Number two, number three, there may be diplopia as well during our examination. The examination technique, I am not going to discuss. The similar way we will just perform the examination. Okay. And after that, there will be paralytic squint that is prominent. Okay, but the light reflex will be preserved, right? Light reflex will be normal. Okay. So pupillary reaction basically. So these are the finding in six nerve palsy. Now, apart from this, we need to do the whole the test. That is, we have discussed the steps. So all the steps we need to do in this eye examination. This is another case in the exam. So according to this case, they will ask the causes, maybe what are the causes. That is, most common cause is increased intracranial pressure. That is maybe due to tumor or maybe due to leukemia, hydrocephalus, sometimes blood pressure, high blood pressure, sinus infection, just like meningitis and intracranial hemorrhage due to trauma. And within these tumors, there may be craniopharyngioma or brainstem tumor, astrocytoma, all this medulloblastoma. These are the causes of this six nerve palsy, and this is very common in pediatric population.
Can I ask one question, Doctor?
Sure.
So if there is no obvious squint on examination, we still go on and do cover and cover test?
Actually, no need, I think. Cover and cover test usually not asked in the exam. Usually, but if you are saying this is a case of squint, definitely there will be the card, and that is the clue we need to identify. There is a squint, and we need to do the cover and cover test.
Okay.
So this is the second type of case. Now we'll move for our most common exam case, facial nerve palsy. Okay. So facial nerve palsy, there are several exam cases. This can come as video. This can come as clinical case. And if there is base palsy or facial nerve palsy, definitely they will give. Okay, definitely, no doubt about it. Very important exam case. So what we'll do, just move that. This is the typical case of facial palsy. So what exactly? So all we know, we can have a read over from the book, but with real cases, sometimes that will be difficult to identify whether this is a upper motor neuron lesion facial palsy or lower motor. That is the area we need to identify. Okay. So if we got a case like this, then what? Okay. So if this is a case of facial palsy, then what are the steps of examination of facial nerve palsy? Can anybody suggest what are the steps to do in the examination of facial nerve palsy?
From first of all, you will give a hand over heart and ask her to look at the ceiling to see is there any wrinkling of the forehead.
I am talking about the approach basically. It's
Okay,
not
approach.
like directly you can ask the patient. You have suppose this is your patient who is just 14 years of age. His name, her name is Samia, or maybe give some name. Soma.
Actually,
Soma.
she is having, facial angle of mouth is deviated to the right side. So there's a left-sided facial.
I will just play the whole video. Before that, you just suppose this is your patient. Yeah. So this is your patient. This is your patient. Okay. Suppose this is the picture. So now your task is to examine this patient. Okay. Maybe if I examine the face, maybe the comment will be just like that, and the approach will be same approach will be there. Okay, so the first thing, we'll enter the station, just describe like that. Okay. Hello.
Bolo.
This is your clinical station. Just you have entered the station. Continue.
Actually, I don't know what are the steps. Well, I know about steps.
Yeah, that is nothing. So I will enter the station. I will wash my hand. I will introduce myself. I will observe for any kind of dysmorphic feature is there or not, including the head size, height, weight, any devices is there or not. Okay, any distress is there or not. Everything. Just like that. So this is the first step, because sometimes there may be head size involved. Suppose this is the post-operative case of upper motor neuron lesion. Some tumor has been resected, and after that, this facial palsy is remaining. So head size sometimes important. Microcephaly may be there. I will talk to the child. Okay. So sometimes mentality may be low IQ may be there. So that's why all these steps are very, very important. Okay. Then what happened?
You are telling like a real scenario, real exam scenario.
Yeah.
Okay. So what is my task? What is my task?
Please examine that this child who is 14 years of age. Examine his her face.
Examine her face. Okay. So I have entered the station and hand over the exam sheet to the examiner and doing my hand hygiene. Asking permission from mother. Mom, can I am Dr. Abhishek, one of the candidates today. May I examine Shara?
Yes, sure.
Hello, Shara. Do you go to school?
Yes.
How many friends you have?
Okay, so whenever she is speaking, his face is deviated, as you can see in the video. I will show you just after your examination. Please continue.
Okay, I am closely looking at Shara Is he appears to be well grown for his age, or short, or tall for his age?
Is well grown.
Okay. Is there any obvious dysmorphic features?
No, no.
Okay. Is he in any distress?
No.
And is there any device, any hearing aid, or is there any hearing aid or any IV cannula mark, or is there anything oxygen saturation probe, anything, any device?
No.
Okay. Okay, Sarah. I have to examine your face. So I would ask you to do some maneuvers. So if anytime you feel any discomfort, please let me know.
Yes. Yes.
Okay, Sarah.
Sure. Sure.
Okay, I am closely looking at Sarah, and I am right now ask her to smile for me. Sarah, smile for me.
Yeah, she is.
Lag behind. The patient cannot close the affected eye.
Okay, she is smiling.
Yes, I can see she is smiling, and I am looking at the nasolabial fold, and I can see the left side nasolabial fold is absent, and the angle of mouth is deviated to the right side. Okay, then I am holding her head and ask her to look at the ceiling. I am looking at the wrinkling. Is there any wrinkling of the forehead present or not?
Okay, so there is. This is a facial. I mean, Bell's palsy. Okay, so left-sided or
then
lost.
there's a loss. Okay, and I ask her to, Sarah, please close your eyes tightly. I will try to open it, but please don't let me do that. Okay.
So here you can see there is weakness. She is
Yes,
unable
I can
to
see
close
there's a left-sided weakness.
weakness, and she is totally unable to close the left eye
Close her left
properly.
eye.
Okay.
Yes.
There is weakness whenever you are asking to close eyes, and there is weakness, not closing properly.
Okay. I will. I am asking her to whistle for me.
So, so whistling also, there is paralysis on the left side. So that is also difficult for.
Now I am asking her. I am to read an bedside object for me. Any bedside object, or is there anything in the wall? I am asking to look at and ask her what is that.
Nothing is there.
Okay, see, okay, now I am doing the age test to see any nystagmus or any squint.
So in the facial nerve palsy is really necessary. There are just
No,
only few
that's
steps.
not. But if my task is face, then I have to examine his eyes, I think.
Yes, right. You can do that. If you have time, then definitely you can do that. But
And
yes,
and then check the limbs also. Then I have to check the upper limbs and lower limbs. Maybe hemiplegia, maybe a hemiplegic patient.
yes.
Because if it is human, usually, and I have to check her ear. Is there anything around the ear? So any vesicles like and I have to check for the hepatosplenomegaly also, and offer the examiner to ask for the BP and fundoscopy.
Yes, BP is important. So what will be the steps? First of all, you did most of the steps, but if you see that if you divide actually the steps, that will be easier to remember, because otherwise in the exam that will also, if we are starting with the face, suppose this area, if we divide the face into just like okay, in this area 1 2 3, okay, so first whether it's upper motor neuron lesion and lower motor neuron lesion, that will be prominent by first this number 1, and number 2 this eye, and number 3 is this area cheek and face. So we'll just ask the patient, you can come from 1 to 3 just like that, or maybe below to upward. So first of all, you can say just, can you smile for me? So whenever the ear will be smiling, the patient will say that will be deviated in the normal side, right? So just like that, in this way. And there will be opposite side, nasolabial fold will be reduced. At the same time, you can ask for whistle and clench the teeth or show me your teeth. There will several same finding will be there. That will be just deviated on the side. And after that, puff. Okay, puff out your cheeks. So again, if this side is paralyzed, so definitely this will not be prominent. Okay, just like this. And after that, if we go into the eyes, then we will ask the child to close your eyes. So this side eye closing will be incomplete. So here, somewhere here will be incomplete eye opening. For that reason, sometimes there may be features of keratitis because this is exposed for a long time. So we need to observe for that. And after that, we'll ask the patient, as you said, Dr. Abhishek, that we'll ask to close the eyes forcefully. I will just, just put my fingers over here. I will not let you close the eyes. Just forcefully try to close the eyes. So there will be weakness of the ocular muscle. Okay, these two steps basically is for the eyes, right? And after that, I will just check whether this is the upper motor neuron or lower motor neuron. At the same time, if there is loss of reticle or the spleen in this area, definitely this is motor neuron. And this is, if this is upper motor neuron, at that time this wrinkling will be just normal wrinkling, right? So these are the findings in our examination. This is basically we are checking the facial nerve. Now, as you said, to complete my examination, this is perfect that we need to check for blood pressure, number one. Number two, any ear infection is there or not. And after that, any skin rashes is there or not. And any exposure keratitis, just I said, just like that. No? Any exposure keratitis is there or not. And after that, hepatosplenomegaly, as you said, all these things we need to check. But most common exam case is Bell's palsy. So this is the diagnosis of exclusion. No need to do any kind of test, but we need to find out the causes, the etiology. So first is idiopathic, second is maybe due to chronic otitis media. Sometimes at the same time we need to check the what is that called? Mastoid process, right, Abhishek?
I don't know about the mastoid process. I don't know.
Yes, if this is chronic otitis media, that can involve the mastoid as well. There may be swelling. That was given in one of the video station. Okay, there was Bell's palsy. That was secondary to otitis media, and that extending up to the mastoid process. There was mastoid process swelling and redness was there in the video. Okay.
আজ ক্লাস হচ্ছে গো, সবাই চলে গেছে।
এটা থাকে তো অনেকের ক্লাস।
ওকে ওকে। না কোন গ্রুপ, কোন কোথাকার? একাডেমিয়া? তাই না?
হতে পারে। একাডেমিয়া স্যাটারডে করে ক্লাস না। Anyway, so these are the areas we need to check. Okay, and rashes for Lyme disease, Guillain-Barré syndrome, sometimes congenital maybe. Congenital are children are very small, and babies that can be given in the video only. And if this is upper motor neuron, what may be the causes? That is sometimes cerebral palsy, tumor, and Mobius syndrome. Okay, management we all know. If this is idiopathic Bell's palsy, then definitely we'll exclude the other causes. As we just said, hypertension and this infective causes, and management will start with good eye care first of all. After that, if this is present earlier within 7 days, then steroid has little role, but we need to consider whether this is coming earlier or not. And after 7 days, steroid has minimum role. So if this is infective etiology, like some viral infection, then we can combine this with the steroid and oral acyclovir. Okay, this is management, and management has been given in the guideline as well, so we can have a look over there. And prognosis in Bell's palsy is very good, usually 6 to 1 year. they will be completely fine. But they need to come for the follow-up. Okay. Okay, guys. So I think today we'll just stop here because I am also not feeling good today. So again, tomorrow we'll just start with the